And go ahead. Okay, there we go. I can't see screens just because I have the PowerPoint pulled up, but can somebody come off mute and just tell me if you're able to see Preceptor Education, able to see
Yes.
acknowledgements, change of screen? You can see the acknowledgement page too?
Yes.
Yes. Okay, awesome. Thank you. Okay, so also wanted to start off by saying thank you to all of those that have been working so hard to orient, all of those that are on orientation. Jordan and I truly understand, all that we are asking. All the new people that we have onboarding that are, starting on our unit, but your hard work and dedication really is filling our unit with safe and caring nurses. So we really do appreciate all that you are doing. So want to start off with kind of just like a brief overview. So preceptor responsibilities, really like we want you to stay connected. We want you to be present for 100% of, care tasks and activities until the final tier of orientation when we're talking about TSAM in our tiers 1 through 5. Um, we do also, want you to have like frequent debriefs like throughout the shift, but also just at the end of every shift of just asking the orientee, like, how do you feel that that went? Whether that is, briefly after something, after a hands-on care, or at the end of the day, just giving them some time to debrief, like, also kind of helps you debrief on the shift of seeing, how they felt the day went, because that also brings a lot of self-awareness kind of back to, maybe this person doesn't have any idea that, like, we really did struggle with time management today, or there are a lot of things that we need to work on with communication. This question of how do you feel that that went really just opens the doors for maybe you not having to have that, constructive feedback conversation of, these are things that we need to work on. They bring it up on their own. And I will say that I feel like at least, I would say 90% of the time they are self-aware of the things that they need to work on. And this just gives them the chance to kind of, make that, close the loop on realizing that things could have gone better. Um, but then there is that 10% of the time that they are truly unaware, and we need to have those conversations, which we'll talk about that in other slides. Um, we are going to talk about this a couple of other times, but please, 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 immediate escalation of any safety concerns to either myself, Jordan, or any nursing leader, the educators, just bringing it up to anybody, even if you feel like this is something that's like it's very early on. You don't feel like it's a red flag quite yet. We have time throughout orientation to work on this. We would rather know about these things at the very beginning. Then did you see some can you move that? Thank you. Um, we would rather you guys bring that up to us in the beginning so that we are able to at least make note of it. We might not give feedback on it right away, but that we can intervene if it's something that needs to be given, like we need to give that feedback immediately, or we just have note of it for later. So please, 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 immediate escalation to us, which we'll talk about kind of the process of that as well. So roles and responsibilities of the preceptor. So I want to talk about the fellowship binders. So a lot of you are probably familiar with the binders that the orientees are required to carry around with them for their entire orientation. Um, I wanted to just go over the binder because I do feel like a lot of times when I talk to preceptors, it's like, very, you guys already have so much on your plate with, what is going on in the unit in general and the responsibilities of taking care of your patients. I do not want you guys to feel like the paperwork is just one more thing that is, there are certain things that we do have to ask you guys to fill out to make sure that we are at, the correct milestones within orientation, but I do not want the paperwork to feel like it's just one more thing on your plate that doesn't allow you to do your job, which priority is patient care. So really want to just start with, the binder. The TSAM objective form is the first form that is in the binder, which if you guys can see my screen, you can see me, you can see the objective form here. So this is a TSAM objective form that breaks down each blurred. It's blurred. Oh, okay. Can you see it now? Yeah, okay.
I think it's only going to pick up your face because you have
Oh,
background blur.
okay. So I can pull it up actually and just share the screen. Oh, so the TSAM objective form is the only one I'm going to share with you guys just because um it is the only form that is required by you guys to fill out with your date and initials. 1 second. TSAM. Sorry, guys, I didn't have this pulled up and ready to go. Such a checklist. Here we go. Okay. So let me get back to you guys. So this is able to see the objective form.
Yes, sorry.
Yes. So this is the TSAM objective form that a lot of you guys have probably already seen uh, in your orientees binders. So this really breaks down what is involved in each tier. Tier 1 being vital signs, assessment, cares, and documentation. And then we'll talk about the tiers actually in previous slides. But really just want this like 4 roles and responsibilities. This objective form does need your initials and the dates because we need to have this turned in to get the TSAM orientation off of our orientees health stream. The other thing that is your responsibility is also the health stream checklist, which I will go over with our new preceptors, how you guys get access to that and how to find it on your health stream. But this objective form, just as you guys are, going through different skills, you're taking care of, thermoregulation, you are demonstrating and they're demonstrating correct positioning and handling of an infant that you're going down through and you're initialing and dating when they complete these skills within these tiers. I'm not going to go over each of the tiers because we are going to do that. We're going to do that in other slides later in this preceptor education. One thing that I do feel like I just have to remind people of is there are signatures on the back. I just need a preceptor signature and the orientee signature on the very last page to complete the form. Does anybody have questions on the TSAM objective form? Okay, awesome. Let me just get back to the PowerPoint. You guys will also notice a TSAM checklist. I won't pull this up, but it's a checklist that you guys will see in their binders that it really breaks down the tiers 1 through 5. It takes the health stream checklist that is very long, very daunting on health stream, and it breaks it into tiers. So I did that when we first rolled out TSAM just to kind of help navigate, the specifics of what is involved in each tier and how it's specific to NICU. I feel like the objective form is very objective. It's very summarized, and I feel like the TSAM checklist just kind of helps with those little details that fall into each tier that can be a little bit more specific. Again, this is not something, it's more of a navigational tool. It is not something that we need back from you guys. It is something that we like to reference during our check-ins just to make sure that we are progressing through the tiers. But it is not something I want you guys to feel like, oh my God, okay, I have to do the objective form and the checklist and the health stream checklist. This is really just a navigational tool to kind of help us make sure that we're progressing through the tiers and not something I want you to feel like is just another thing that we need you to fill out. We do have an assignment tracker in the binder as well. This is the orientee's responsibility to fill out. This is something that we put into the binder because, if we have orientees come to us and say like, I really am just like not getting enough acuity or vice versa, we're able to go back and look at the assignment tracker, which this is the orientee's responsibility to fill out week to week of what they are seeing in their assignments, whether it's three babies, what kind of respiratory support they're seeing, what kind of central lines they're seeing. But again, it's another navigational tool for if, like, you guys are curious, you're welcome to look at it. But it is something that sometimes we will just ask to see in check-ins if we are getting these kinds of, we're getting this kind of feedback that they're only getting three baby assignments or they're not seeing central lines. We can go back and kind of look at this assignment tracker. And then we have the biweekly QR code, which we are going to go over in this next little section. Recently, especially for those that are newer to precepting, we have changed over from the biweekly forms that were just a paper form to a biweekly QR code. The biweekly QR code goes to a Teams form where you guys will fill out the biweekly check-in together with all the same information that was on the paper form. But I will go over that in this next little section. But first, I want to talk about biweekly check-ins in general. So really want to just talk about, biweekly check-ins are a time for feedback. I will say that, this is a time where we really do rely on you guys being our eyes and ears on the unit, and that we aren't, with these orientees at the bedside seeing in real time what is going on. That being said, we understand that feedback is tough. We understand that not everybody is going to be as fluent in bringing up something that it's just constructive. It shouldn't feel punitive. It shouldn't feel negative. It really should be constructive and something that's supposed to help this orientee grow. But at the same time, we understand that feedback is hard. But if you are unsure of how to give this feedback, if you are unsure of how to even, bring it up to them, bring it up to us, but we do expect you guys to bring it up. Even if are unsure of how to bring it up to the orientee, please come to Jordan or I prior to the check-in, knowing that you guys have the check-in scheduled. Come to us first, let us know, like, hey, I'm really having trouble with them, taking the feedback I'm giving. They're not very receptive, whatever the situation is, bringing that up to Jordan and I, and then we can help navigate that conversation. I really do feel like like a lot of the times we will be in check-ins, we'll have a check-in that we feel like goes really well. They seem to be on point. They're progressing through the tiers. No, no complaints, no barriers, no challenges, no feedback given. And then we will have people come to us after the check-in and tell us that something is going on and they are having issues with their orientee. This is frustrating for us because we don't want to waste your time in putting you guys through another check-in, another 30-minute check-in, where we're having to give this feedback. Again, we understand that feedback is tough, but just bring this up to us prior to the check-in so that we can address these concerns. We can find ways to bring these concerns up gracefully. We can help you bring up the feedback in real time if it's a situation that's we can't bring this up organically in the check-in. These are things that Jordan and I just need to know prior to so that we can facilitate the conversation to go the way that we need it to. Does anybody have questions about feedback or personal, experiences with feedback where they feel like maybe they weren't heard, they feel like you guys have constructive feedback for us? Because we want the feedback back. If there are conversations that you feel like maybe could have gone more gracefully, you feel like experiences where the biweekly check-in wasn't set up to bring up that feedback, we want to hear it. But does anybody have experiences they'd like to share with the group, especially for the first time preceptors? Don't want to put you guys on the spot, but I love when people share like a personal story. It just kind of brings it full circle. But or any questions on feedback? No? Okay, awesome. So biweekly check-ins. So like I said, the QR code is something that we are now utilizing. The QR code takes place of the paper form that we used to use for our biweekly check-ins that you guys used to be able to, grab and print off of Canvas. This QR code leads to a Microsoft Teams form. So I'm going to actually stop sharing and pull up what this QR code looks like. second. Okay. Okay, can you see okay, great. So this is what the form looks like on a desktop. It'll look a little bit different when you are on a cell phone, which most of I feel like you guys can, snap a picture on your phone and it brings you to the QR code, the Microsoft Forms onto your phone. But it has the same context. So one thing I do want to bring up is there is like a 90-minute timer that will be brought up when you first log on to the QR code. I don't want this to scare you guys. This does not take 90 minutes to fill out. It just times out at 90 minutes, giving you guys time that if you are starting the QR code, you don't need to finish it within 5 minutes before it times out. You do have 90 minutes to fill it out. You do need to fill this out together. It's not something that you can scan the QR code, then they can scan the QR code. What I would have the orientee do is scan it on their phone, and just go through the process of filling out their name, all of the different contexts, and then you can fill out your portion at the end with your scores on the tiers and then any feedback that you have. Um, so what it starts with orientee's name. So please just put the full orientee's name because this does go into a bank with all of the other children and pediatric service lines. So just making sure that we have the correct Olivia or Sophia, because there's a lot of them. So full name here. Then you're going to put if they are a new grad or a fellow. A new grad being they're fresh out of nursing school, a fellow being that they have experience from another specialty and they're coming to us. Care site, so we are IFMC, of course, unit name NICU, and then your full name here as the preceptor. Then you'll put the biweekly date here along with the orientation week. So ANOVA week being week 0, what week they are in. And usually we are checking in on the even week, sometimes the odd, but weeks 2, 4, 6, 8, all the way up through 12 to 16 weeks. So which of the following team members did you meet today? So you'll either put, clinical mentor, or you can put other, because we do have 2 members of the fellowship support team that do check-ins with us, Julia Pina and Jenny Antonellos. So just putting who you're checking in with there in the other file. Then this is one question that we get a lot. So current tier that you're focusing on in TSAM. So not the tier that you feel like they should be in, like the current tier that you feel like they're operating in. So if you feel like, even though they're in week, let's say 10, but they're still in tier 2, putting that they are currently in tier 2. This was also confusing for some which we're going to go over the tiers and what falls in them for those that aren't as familiar with TSAM. But then we get into the tiers of tiers 1 through 5, and then how to score them. 1 meaning that they did not meet objectives at all, up to 4 where they are meeting the objectives independently. And ideally they are scoring 4s, like before going into their next tier. But I will say that it is common that, we're still working on things in tier 2, but we're still getting experiences for tier 3. So we're not wasting time on orientation. Just making sure that, we're not halting any progression. If you do not feel like they are in tier 3 yet, you do not need to score them. But if, again, it's one of those situations where they're in tier 2, they're still needing minimal guidance, they're giving medications, but you're still needing to give prompting on in-pass scores, I don't know. But you are still doing communication or seeing admissions and discharges in tier 3 or 4, you can still score them on that. Sorry, I don't know why that timed out. So it's really up to you guys. If you're seeing opportunities where scoring them is something that we can do, please by all means throw a score in. But if they aren't showing any opportunities to show scores for admissions and discharges, don't put anything for tier 4. That's totally fine. Then there's an opportunity, again, just like the paper form for the orientee, to rate themselves on, ANOVA mission and values, willingness to learn, asking appropriate questions and recognizing when assistance is needed, anticipating trends in patient condition, and managing priorities and tasks. I will say that for these first three of asking appropriate questions to ANOVA missions and values, we do always really expect to see fours here. If we see threes from you guys, we will like bring this up in our check-in just to make sure, because they should always be upholding our mission and values. They should always be willing to learn, and they should be, asking appropriate questions or recognizing when they need assistance. This is, if we see that you're scoring them threes here, we're just going to kind of see that as a little yellow flag of like, are you guys doing okay? Like, are they being receptive to you? Are they asking questions? Things to that nature. Anticipating trends and managing priorities, we understand that that can sometimes take a while. So scoring them appropriately there. This is for the orientees if they've just turned assignments in on time, health stream modules completed, just a little note for us. This is when we get into the preceptor ratings. So you guys rating the tiers. So that's where, orientees will do their scoring, and then you'll take the phone or get onto the link and do your scores here of scoring them 1 through 5, and then you doing your ANOVA mission and values and managing and priorities and anticipating trends. Then just a little reminder for you guys of have you updated HealthStream, just because that HealthStream checklist is your guys' responsibility. They're not even able to access it. Just making sure that you guys are checking in on that HealthStream at least once a week, if not every other week. Then there's a little spot for them to reflect on an experience that they learned from. So that's for the orientees, collaborative goals for the next 1 to 2 weeks. And then any assignment requests or feedback from you guys. We do also have, we are updating this QR code with the system. It's not just with us. We have like a whole work group for it with professional practice where we're updating this QR code to make it just look a little nicer. Feedback that we've gotten from you guys, from other units, where we will have like a little note section. This is like a little goal setting plan where like sometimes like you could throw goals in a note, but we will have like a separate note section in general. Does anybody have questions on the QR code and the changes with the form? No? Okay. All right, so back to the PowerPoint. So we went over all of these things. Anybody have feedback or thoughts about the QR code that's used them? No? Okay. And then just one more plug for feedback. Again, these biweekly check-ins are the time for feedback. But you know that we are always here for you guys. I feel like Jordan and I are usually here pretty early in the morning for those that are here on night shift toward the end of your shift. But we also love an email, a phone call, whatever you guys like. I've, talked to people on their way home, on their drive home in the morning, like whatever is the most convenient way for you guys, because we want it. We want the feedback. We need it to make sure that these new hires are progressing and have the support that they need. So please, 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 if you take anything away from today, please bring that feedback to us in real time. Or give it to your orientees in real time if you feel comfortable, or bring it up in the check-ins, if not prior to us, so that we can facilitate the conversations so that they can happen. I'm going to briefly go over TSAM really quick, just for those that aren't as familiar with TSAM. So TSAM stands for Tiered Skills Acquisition Model. Really, the idea is that the orientee has access to the full assignment throughout the entire orientation period. We should not be in the delegation mode anymore. I will 100% admit that when I was a preceptor, I was a delegator. I felt like I was like, here's your room air kid. You are going to be doing, this baby's care for, the shift. We are really trying to get away from that mindset, and that TSAM really has helped with the progression of putting larger, more complex skills on that orientee's plate so that they're able to handle the assignment as a whole and transition off orientation more successfully. This is our model for TSAM. Again, won't go through like all the nitty gritties because we have them in the next couple of slides, but this is a really nice model that you will find in your orientees binder if you ever have questions on TSAM and what is the responsibility of the orientee versus what is the responsibility of the preceptor. This is a really nice breakdown of what falls into each tier for orientee and for preceptor. So the objective forms, totally forgot I put these in here, so didn't need to pull up that screen earlier. But so tier one really should be starting off, with making sure that we are covering vital signs, assessment, cares, and documentation. So really covering with them, hourly rounding, safety checks right out the gate. They should be in charge of their own safety checks, which will go over their expectations and the education that we even give them. Thermoregulation, correct positioning and handling of an infant, and overall just what is involved in hands-on care for our patients, along with making sure that we have timely documentation, what goes into our hourly documents, along with all of our assessments. Tier two, we're getting into medications, orders, milk preparation, feeding, and specimens. So this is where we're getting into, making sure that they're seeing all the different kinds of meds, oral, gastric, transpyloric, G-tube meds, meds over the IV pump, over our Medline system, making sure that we're seeing all those different routes and that they're practicing 5 rights. Medications, we really have tried to just take a totally different, not different approach, but I think a more strict approach, and that these orientees need to be looking up everything on Neofax. Even if they have experience as RNs, they do not know what we are using caffeine for. That to them is not something that they've used in the adult world or understand why we're using it for babies. So they should be looking all their meds up on Neofax. They should be proving competency by doing med calculations and showing and proving to you guys that they know how to do med math and they have the correct mLs that they're giving with the proper dose, that they've made those correct connections to get them to the correct mLs of medication that they're giving. So please make sure that you're just also encouraging that, you're influencing that, you're demonstrating that everything is being looked up, that they know their proper dose, they're doing their calculations, and they're giving meds appropriately. Along with milk preparations, if they're on ISO, we need to make milk, IDF for feeding, queuing, scores for IDF, and specimens doing labs, heel sticks. We're doing UVC, UA, lab draws, things like that. And then also IV pump hanging fluids, grabbing correct supplies, starting to get into those central lines, because we do not want to wait any longer than tier two to start hanging lines because they need to have that practice immediately. Tier three, so this is going to be care planning, high-risk procedures, and communication. So these are going to be things like placing feeding tubes, management of replogals, overall, communication within the care plan team, that being with the providers, respiratory, OT, lactation, creating a plan, communicating with them when cares are, when they can come by, if lactation has appointments with mom, that they're doing that communication, that they're doing those SBARs with their providers if there's anything that they need to escalate. And then they're also doing education and communication with parents. That they're working with high respiratory support, that they are troubleshooting alarms. They've taken NRP at this point, so they know the basic steps of, needing to stim, needing to, suction, do O2, things like that. They should be, that is tier one, though, that they should be answering alarms and acknowledging what alarms are. You should not be needing to prompt them at this point, but they should be, better at troubleshooting the alarms and what's going on. Delegating, practicing delegation. I always like to, in check-ins, just start practicing with you guys, that even if they don't know what to delegate, that they are at least acknowledging that they're acknowledging when they're getting behind, and that delegation is needed to stay on time and to stay up to speed with what's going on in their hands-on care. And just doing like little role playing with that too with them, that like, okay, let's pretend like you don't have a preceptor here that's not doing anything to delegate. Who could you delegate this to, so that they're delegating to the appropriate resource, whether that be their pick nurse, transport, unit supervisor, point person, that they're just reaching out to the appropriate resources, because they're going to get behind. Time management is going to still be something that they, possibly struggle with coming off of orientation, but they need to know who to reach out to. And then just starts to demonstrate critical thinking. Again, just connecting the dots, putting the pieces together, and helping them with that. Just talking to them about, okay, first round of cares, like what are our patients' big priorities for today? What are things that we can, talk to the doc about? What are conversations that you're going to have and put a part of your S bar? So having them put those S bars together, um, connect those dots, start having them, do the thinking on their own, and then help navigate them from there. Okay, so this is tier 4. So this is going to be admissions, discharges, transfers, and more communication. So, this is really where at this point we really should not be worried about that they know how to do a hands-on care. That time management is a real concern with a very stable, basic patient. So this is where I do want you guys to advocate for them to go see admissions, go see discharges. It's not every day that we get, an admission in our assignment, or we have a discharge. Send them to even other neighborhoods just to see them, them do discharge education with a family, or even just walk the family from the room to the secretary's desk when they're being discharged. We want to just prioritize them seeing these experiences, rather than them stay and do a hands-on care, which we know they already know how to do. Also a part of this, just like further education with families, Epic Chat secure, like, what you can Epic Chat do's and don'ts of that. So just kind of helping them navigate through that. And then tier 5 is just full workload management, so that they're able to be organized, prioritize, throughout their assignment, that they're able to acknowledge when they're falling behind. Again, like we talked about, that they're able to just put this all together and be able to handle a full patient assignment without direction from you guys. If it's something new, it's appropriate for you need to like navigate a little bit, but for them to at least reach out and say, hey, I don't know how to navigate this. Can you help me? So that we can at least just see that they are going to ask questions when they're coming off of orientation. So that's tier 5. This is just kind of, why TSAM, things that we went over in previous slides. So I won't take time to kind of go over this. Really just kind of, giving evidence to why we use it, and that new hires often struggle with workload, prioritization, or organization. And this really does help with an incremental model, to slowly put more complex skills on their plate, but not before they're ready. So going into feedback, like we were talking about earlier. So again, please, 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 we need to be informed as soon as possible, either myself, Jordan, the educators, or a leader on our unit. We need to know in real time. And even if it's early on and you feel like, they just started, I feel like this, like I'm, being a little harsh, by like bringing this feedback to, the mentors. Again, we don't, come right out and give this feedback right away unless we feel like it's something that is a true safety concern. Sometimes it's just nice for us to have this in our back pocket, have note of it, so that if it comes up in future check-ins, we can say like, oh, you know what, like Jordan did bring this up to me, like this was an issue, week 2, but thankfully, we had somebody come and fill us in on this prior to, so that we know this has been a continued concern. Sending us feedback in written form is the most helpful. I will say, like, I love when you guys stop by, fill us in, tell us everything that's going on. We are all for that and happy to take that feedback. But the way feedback really does work, like we need something in written form. That is where it is most helpful. So if you don't have time to stop by on your way out from a shift or even to come by during your shift, just a written email in detail what is going on, the things that you're observing, that is truly what is most helpful for us, so that we can kind of just, save the feedback for ourselves and have things in written form. Um, Please help us bringing up this feedback in real time, if not in the check-in setting. Again, I know that we talked about this prior to, but we really do, if this feedback is brought up in real time by you guys, it's given, at the proper time when it's happening right in front of you. So the orientee understands, like, and they're not getting this feedback 2 or 3 weeks later. This often happens to us where we get feedback on a situation that happened 2 or 3 weeks ago, and and it is a safety concern, but we have to sit down with the orientee and discuss this. And they're like, I don't even really remember what happened last week, And so it just really helps when at least something is brought up in real time, so that even if it wasn't brought up to its thorough nature that, a feedback needs to be given, we're at least able to reference that when we sit down and chat with them. Again, please fill us in prior to the check-in so we can facilitate this conversation in a constructive way. Um, so giving feedback in real time, again, I know that feedback is it's not the easiest thing to give. It can be difficult, it can be tough, but really want you to just challenge yourself to, reconstruct the way that you look at feedback. Feedback is not something that should be looked at as punitive. It should not be looked at something that is negative. It should always be constructive. And it's also not something that should be personal. This is your job. Like, you guys are, again, creating safe and caring nurses. And by not saying something is doing that in like injustice of not, allowing them to have a chance to make the change, to become those caring and safe nurses. But it's your job to give the feedback. They're your orientees, and they deserve to hear it, and you deserve to share it as well. So I think that the biggest thing is, giving it at the right time. Sometimes, in real time is not going to be as effective or appropriate. If the parents are in the room, not an appropriate time to maybe give the feedback if you can't have the conversation, semi-privately. But, doing it shortly after that hands-on care, so that, you're doing it at the right time, but you're doing it the real time. You're not letting things go too long. Giving a compliment and then giving the constructive feedback. I call it dropping the but, because I always will do this, but I will say but too much, but I will give a compliment and then I will say, but, you're doing time management really well, but the communication with the parents wasn't great. I think that completely just drop, because all they will hear is that but, and they won't hear anything that you said prior to that. So I think that giving them a compliment on something and then giving them the constructive feedback. So replacing that but with an and, because, there is a lot of things that they could be doing well, but we need to add to that. So it's just an and, it's not a but, because I really just don't want them to hear, only the things that you're giving them constructively. I want them to also hear the compliments that they have for you. Um, Also, just kind of bringing a realization that being on orientation is really tough. I know that some of you, even in this meeting today, it wasn't long ago that you guys were on orientation. You feel like you're under like a magnifying glass. You feel like everything you're doing is being picked apart. So I just really challenge you to, be in their shoes, see the things that they're seeing, hear the things that they're hearing. So giving them a compliment when compliments are due, giving them, an accolade that they are really progressing in, and then also giving them the things that we still need to work on, that there will always be things that we can improve upon, and that we can add to our, progression on orientation. Again, I know I'm like repeating myself. I'm very redundant this meeting, but please, please, please talk to Jordan or I if you're like, I have no clue how to even have this conversation. there are some things that, are tricky to talk about, but that it's our jobs, and we're here to help with the tips and tricks on how to have these conversations, therapeutically, constructively, professionally. Um, so popping over to HealthStream. So HealthStream, that is along with the TSAM objective form, is the other thing that is purely the preceptor's responsibility. This is a very long checklist, as a lot of you guys remember. So please, please make sure that you're checking this every week, if not every other week. If you are new to precepting, we will be getting you access to this evaluate checklist link. So you can see this little image right here. When you sign on to your health stream, this is your to-do list, and then you will have options over here on the right-hand side and this little highlighted area that says evaluate checklist. That is how you know that you have access to the checklist for your orientees. Um, if you do not see this within the first, like a shift, like with your first shift with your orientee and you're new a preceptor and you do not have the evaluate health, the checklist link, please reach out to Jordan and I. We will get that taken care of for you. It really just takes a day. It does not take long to get you guys access. So please just let us know if you're missing that option there. As you get started, as you start to get to the end of orientation, please just look for opportunities. The things like admissions, discharges that continue to linger, PIV insertions, pick placements. These really are opportunities that those things that are lingering on the checklist, send them to go do those things. Make sure that it's an appropriate experience, that family's not at the bedside, that these are just things that are going to add to their orientation experiences, but I rely on you guys to know what's appropriate, what's not. But please advocate for them to go see those things if they're lingering on their checklist. Does anybody have any questions on health stream, the checklist, or the link for the checklist? Wonderful. So healthy habits. So these are things that we teach in like our first class days, our small groups with the orientees. So just felt like it was helpful to share with you guys. So arriving to work on time and appropriately. So again, please let us know. We have Saj that checks our time cards, but there's so many time cards that she's checking that sometimes it doesn't get caught until later. But if this is somebody that is like rolling in late, clocking in even like past 7 p.m. is something that we tell them is inappropriate. They need to be checking in and clocking in and making it to huddle every morning. That they are adhering to our proper dress code. Abiding by all of our infection prevention policies, and the dress code that goes along with them. But if you are, seeing that these things aren't being upheld, please, please let us know. Safety checks. We do expect like right out the gate that they are in charge of safety checks, and we do have a resource for this that I will show you guys after this little slide. But we do a teaching round within the first 4 weeks, 6 weeks of their orientation, where we do a teaching round at the bedside where they do need to prove competency in their safety checks, which we will go over the expectations of all of the safety checks that need to be done. But they are given this resource and are expected to have all of the safety equipment checked in the room. Please also ensure that they're, instilling that you guys and that they are practicing organized habits and expectations, that rooms are clean and tidy, that you're restocking your carts for your next shift, setting your next nurse up for success, and that the baby's always put back nicely. That should never be, not a part of your time management, that like, oh, I've got to get to my next baby. I don't have time to like just even take a look around the room and throw trash away, or put things back nicely, and especially have the baby put back nicely. You never know when parents are going to come in. This should always be an expectation. They should always be going in early for hands-on care. They are learning. Their time management is not where it needs to be, like pretty much throughout orientation. So they should always be going in early. And the goal really is to have feeds starting by the time of the baby's care time. So however early they need to go in, just making sure that setting that expectation that the feed should be started on the care time so that baby is on time. Again, an organized hands-on care. So they're starting from the head of the baby, making their way to the toes. They're starting with clean tasks, finishing with dirty tasks. Um, I know everybody does things a little bit differently, but we do share this picture with them over here in their first class day of even like setting up their bedside cart with the materials that they're using for that hands-on care in the order of which they are going to complete those tasks. I just like to teach them this in the case that, you know, a parent comes in and wants an update or even a provider, that they have their bedside cart set up in this manner and that they're able to look and say like, oh, like I was just getting to my oral care kit, so that's where I left off my hands-on care, because they're learning, they get derailed easily. This is just like a nice little reminder that keeps them on task and keeps them organized. So happy for, you know, you guys to, you know, continue to encourage that if that's something that you guys want to you know, add to your practice of precepting, but just something that, you know, I had with my orientees, I had them do, and something that I just plug for our fellowship as well. Time management concerns. So if you come to us and you say like, I don't know what's going on, but like time manage, like we're spending an hour in the room. The first thing that Jordan or I are going to ask is, so what's going on in the room? So I think that just like kind of making a note to yourself that if your orientee is having time management concerns, to just spend time with them in the room. They shouldn't be in the room alone anyway, especially if they're having time management issues, but really observing what's going on in the room. Are they just taking a long time? Is their approach to the hands-on care or the assessment disorganized? Are they not grabbing all their materials and they're popping in and out of the room? So we will have those questions. If you guys come to us with time management concerns, we will just ask like, hey, well, like what are you observing at the bedside? Like what is taking so much time? So just kind of wanted to plug that because I feel like that's something that we get often. SBU. So for our SBU preceptors, those that will precept in the SBU, I did want to just make like a little slide because it is different rules and expectations. Orientees should never be alone in the SBU. This is a totally different patient population that we really need to be very particular about, protective over, and making sure that the orientee is upholding all of the expectations for this very vulnerable patient population that we have in this neighborhood. Um, I will say that it is very appropriate to see a mild regression. So if like you are with your orientee for the first time in a couple of weeks, you guys happen to be in the SBU and you're like, they are not able to do any of the things we were doing a couple weeks ago. They aren't initiating cares. They are, you know, not answering alarms. I will say that this is very appropriate. This neighborhood is very intimidating for a new nurse. And we do share with them that, you know, they shouldn't be alone in the room, that this is a different patient population. They shouldn't just be like going in and starting cares without you guys. So that it is very appropriate to see that little bit of a regression. But the things that we do want to continue to see them do independently and that we want you guys to encourage them to do is initiating cares, not going in and doing them on their own, but saying like, okay, I'm going to get up and do my cares now. You shouldn't have to be prompting that. They should be saying, I'm going to get up and start grabbing my materials and go in. Will you meet me in there in like 10 minutes? But setting the expectation, they shouldn't be just starting hands-on care without you, but they're initiating the plan of care that's going to happen. Making a care plan. So just discussing, I know this is a more critical care, you know, patient population, but that they are at least initiating, you know, okay, this baby, you know, they talked about moving them from a different respiratory support to bubble. So like, would we bring that up to our providers? So they're at least asking those questions that, you know, they're at least looking at labs saying like, oh, this crit looks low. Would we like ask if this baby needs blood? Would we go up on respiratory support for a gas level that we're seeing? So that they're at least looking at those things and they're asking the questions. Answering alarms. So they should be getting up out of their seat, continuing to have urgency, never going alone, never answering an alarm alone. You should be hot on their heels right behind them. But that they aren't needing prompting to, okay, we need to get up, the baby's desatting, we need to get into the room. That they still have that urgency to them. looking for experiences. This is a wonderful place to get, the transpyloric meds experience, to give meds over our med line. A lot of our babies will have caffeine in there or antibiotics. So making sure that they're at least looking around and asking, like, hey, can I ask if I can go in and do that care with a baby that's on a jet? Because they haven't seen a baby that's on a jet yet. That they're at least advocating for themselves to see experiences, and for you guys to encourage that advocacy. The one thing that we do ask is just no inline suctioning for babies that are on IVH bundle. These are not babies they should be practicing on. We do still have the baby doll, the baby head that is intubated with the inline suction. I strongly encourage you, which we have that in the SBU. I strongly encourage that if you have a baby that's intubated with your orientee, have them do a couple practice runs on the baby that's intubated and then have them do the inline suction on an actual baby. But no inline suctioning on any babies that are IVH bundle. But practicing on the baby doll just helps them kind of get that, muscle memory of, like, holding the ET tube where they need to hold it, placing down the suction button and pulling appropriately, that we're not doing that for the first time on a baby. Any questions on the SBU? Okay, awesome. I know that, oh, cool, I've got 5 minutes. So I'm going to share my our safety checks, just so that you guys are aware of the safety check expectations that we teach the fellowship. So this is the resource. Maybe some of you guys have seen it on the unit, but this is, their resource that we give them of what they need to know for their teaching round for safety checks. So we have the nice little NICU safety check, epic, what you guys do at change of shift. But really, discussing the ID band, so that they need to always make sure that they are actually checking the baby's ID band, that no additional bands are permitted at the bedside, hiding under the keyboards, things like that. If there is an arm board change or an arm band change, that we're just making sure that the initials are in, whoever double verified the new band with the from the previous shift, and that you guys check that arm band as well. If there is a safety cube, so alarm limits, so correct alarm limits and parameters. So making sure that they understand that heart rate needs to be between 80 to 200. Respiratory rate 0 to 100. We also make sure that they understand why the respiratory rate is set to 0. Making sure that they are, when we ask this, that they will prompt that, like, babies, our patient population will go apneic. This is something that happens often. So that's why that rate is set to 0. But then we will ask them, so if that's set to 0, though, how do we know if a baby is truly apneic? And making sure that they know that they have the apnea monitor of 20 seconds, that the orientee knows where to find this apnea monitor and make sure that it is appropriately on. SBO2, so just making sure that they understand the parameter of high and when it is turned off versus 96, which I know that all of you guys know, but making sure that they know, that it's not just a baby that's on respiratory support, that we're setting it to 96 if that baby is on respiratory support and requiring more than the 21% FiO2. And why do we care about that? And talking about the ROP, and talking about those babies that are at risk for ROP that are on greater than 21% of FiO2. So just making sure not only that they're just able to regurgitate to us, like, oh, respiratory rate 0 to 100. Okay, but why is it 0? Why are we setting the high to 96? So that they're understanding the whys behind what they're doing. They're not just being robots and doing it. Maps 36 to or 30 to 60, making sure that they also are aware of the patient population, being that nice standard of an appropriate map, so that they know that when they're in the SBU, if they have a 25 weeker, that they're not freaking out when they see maps of 25 to 30. So making sure that they understand that map is not only just 30 to 60, that it's appropriate to be around the gestational age. Then we get into the bag, the AMBU bag. So the things that they need to make sure that they check is the correct mask size, making sure the PEEP valve, so the red top of the AMBU bag is the PEEP valve, making sure that's always set to 5. Making sure that the bag is reinflating, that we're checking the bottom of the bag, collapsing it and seeing it refill, that we're not just listening and say, oh, I hear it, because a lot of times we're, people have done that and we're not actually connected to the right Christmas tree. So making sure we're connected to the correct rescue FiO2 circuit. And then also an extra one is ensuring the override valve is pressed down. So that all ambu bags come with the override valve pressed down. It's the white valve that's on the top. But just making sure that the override valve can cause pneumos if it's not pressed down correctly. So just making sure that that override valve is collapsed. The blender, so making sure that the blender for your rescue FiO2 is set to the appropriate O2 setting so that it always is 10% above what the baby is requiring FiO2 wise. Intubated patients, we will ask, oh, your baby's intubated. What's another safety equipment or check that you need to do? That we have the CO2 detector at the bedside, usually taped to the vent. Suction, so making sure that we have every bedside should have 2 sizes of each deep suction, so 2 6s, 2 8s, and 2 10s. Our suction setup, so our basic suction should always be set up and working. It should always be on, parameters being 80 to 100. I think always going over the education with them to never just like really jack it up or really bring it down if it's at the incorrect setting, because it can bottom out the suction or just send it all the way way too high. So just being very mindful of like very small manipulations to get it where it needs to be. Also telling them, when suction is changed out, making sure that there's a date of when the suction was last changed, and then telling them, the days that we change it, which is Tuesday night shift, by Wednesday day shift, that suction should be changed. Respiratory settings. So they should, if they have a respiratory support in the room, they should always be verifying what is at the bedside is what we see in the order sets. And I think always just plugging, like, the RTs are the ones that do the setting changes, but as the bedside nurses, we need to ensure that those settings are carried out. Work list. This is something that is used nurse to nurse. If that's something that you want to plug for them and they enjoy using that to keep them organized, that's totally fine. Results reviewed, making sure that they looked at their labs with their oncoming nurse, and they made sure to cover any critical lab values that were drawn previously. Checking all orders, IV sites checked. So this is a moment where, really we should have like, lights on to make sure that we do an access check so that you're not coming on for your first hands-on care and finding a bad IV. That you're checking all IV rates, routes, and pumps, making sure that you're double checking that. You're being very proactive about following bag to baby, whatever they're saying is running to what, that you are double checking that. Central line, so the necessity portion of the actual check, just, how long have we had access? Are we able to pull to prevent CLABSIs? And then doing our CLABSI bundle checks, making sure Curo's caps are in place, bag and lines are labeled, dressings are clean and intact. If you have a feeding pump going, making sure that you're checking your orders, you're checking the rate, and you're also checking the label on the syringe, making sure it's for the correct baby. And then always the breast milk. Is breast milk available, just so that we know your oncoming nurse knows what you are feeding that baby for that shift? Is there donor milk in the fridge? Is it mom's milk? Are we doing formula? Whatever the situation is. So obviously, I know that you guys are aware of these safety checks, but want you guys to know the expectations we are placing on the orientees, that these are all things that they should know for their teaching round. These are things that we can ask about, and we want them to not only understand them, know the parameters, but know why we have certain parameters, so that they are understanding to its fullest degree. Awesome. Okay. So we are all finished. Last little slide. Just wanted to thank you guys again for all that you do. Thank you guys for attending. I know this was, we planned this um a couple weeks ago. So I really appreciate you guys putting this on your calendars. Those of you that could make it, please encourage those that are new preceptors. We'll put this recording out onto our YouTube page, and we'll send you guys that link. That's just how we felt like recordings are sent out easiest. So we will put, if you would like to go back and reference this information, the recording will be there for you guys as well. But please encourage those that weren't able to attend. Lots of helpful information for our newer preceptors, as well as those that have precepted before. But we really appreciate all that you guys have done for our unit, for our new nurses. We really could not do this without you. Please let us know if you have any questions, if you have any feedback. Please, please, please. We are always here for you. We're here for it. And we appreciate all that you guys do. Thank you guys so much.